The broadcast is now starting.
Hello
All
everyone,
attendees
my
are
name
in
is Susan
listen-only
Caldero
mode.
and today I'm going to be facilitating the coaching clinic for EKG. So I want to welcome you. This is a recorded webinar, so you have the opportunity to stop and go and take notes as you go along. We'll be covering a lot of information today, and a lot of it is just general information, and we'll get into more specific interpretation of EKG. So once again, my name is Susan Caldero. Thank you for joining. And without further ado, let's go ahead and get started. So let's start. Coaching clinic, and we're going to start with a warm-up question. The warm-up question is, the nurse is analyzing a rhythm strip. What does the nurse look at to identify the resting state of the heart? I'll give you a minute to think about that one. Okay. T wave. If you answer T wave B, you are correct. The T wave represents the ventricular muscle repolarization, also referred to as the resting state. So today we're going to go a little bit further into the electroconduction of the heart as it relates to EKG interpretation. We'll be discussing different terminologies as we go along. All right. So let's start here. I did put in here a link to a YouTube video that goes into a little bit more detail if you're interested in learning more about the conduction system. So you can take a picture of the slide or copy down the link. So let's first start talking about the conduction. The conduction system is made up of 5 elements. We start out with the sinoatrial node. As you probably know, the sinoatrial node is also known as the pacemaker of the heart. It's where the electrical impulses are initiated in a normal working heart. It's also, like I like to refer to as the boss or the captain of the ship, right? The next element is the atrioventricular node, or we refer to as the AV node. I like to also refer to this as our gatekeeper. It's where the impulses kind of hold up before it enters into the lower chambers of the ventricles. As it goes through the AV node, the next stop is the bundle of His, HIS. And then it moves to the left and right bundle branches, and finally the Purkinje fibers. So this is the normal pathway of the electrical current that happens in a normal heart rhythm. So electrical impulses, as I mentioned, is initiated by the SA node, or the pacemaker of the heart. Notice in this picture, you see where the electrical impulse then travel to innervate all of the other pacer cells that are inside the heart muscle area. Once the all of the pacer cells receive the message, there's a coordinated effort that contracts the atrium. If you recall that the atrium are the upper chambers of the heart. So as the impulse reaches both the right and left atrium, you get that nice contraction of the heart muscle. That's that love dub. That's the love in the love dub. Now, once the impulse goes through the atriums, it's going to travel down towards the AV node. And this is where it's located there, right above the juncture between the atrium and the ventricles. As this impulse gets to the AV node found within the border of the right atrium and the right ventricle, the AV node is referred to as the gatekeeper. It has an important job of deciding what impulses are allowed through the ventricles. Next comes the electrical impulses that reaches the bundle of HIS, or bundle of His. It then comes through the ventricles and then subdivides into the right and left bundle branches, as seen by the colors in the purple. Next comes the impulses as it continues to travel down the septum through the right and left bundles, and it causes a contraction of the ventricles. It's that even nice contraction. And then the final stop here is when it gets down to the apex of the heart and we see the impulse traveling through the Purkinje fibers. Notice along the way in all of these pictures, you have this electrical rhythm or EKG tracing. As you can see by this last picture, it represents how the impulse travels to the heart, represented on our EKG. And this is a one complete heartbeat. We're going to talk more about that in just a second. All right. So I don't know if you want to take a picture of this, but that is the normal pathway of your electrical conduction as initiated by the SA node. Now, let's go into understanding how the waves go and how they're represented, what we see on an EKG or electrical telemetry unit. So a couple of things we're going to notice here. First of all, we need to talk about the fact that the straight line, as indicated here, if we look and put a ruler down here, the straight line, this is what we refer to as the isoelectric line. The isoelectric line is when it's the resting state of the heart. That means that there is no electrical activity going on when the heart is in a straight line this way. So as you can see, anything that deviates from the isoelectric line, anything that goes up, we call that a positive deflection. Anything below the isoelectric line, we refer to as a negative deflection from the isoelectric line. Now, without getting into a lot of chemical or anything in deep understanding here, if you recall way back in school when you guys learned a little bit about action potential, remember that term? That relates to how electrical activities are initiated through the exchange of ions. All of your ions are positively or negatively charged. As you get these ions exchanged within the cell, that's what creates that electrical current. It's kind of like when you turn the light switch off of a light and the electrical current travels and then you see the light bulb go off. That is done through ions, and a lot of our positive, negatively charged electrolytes, for example, like potassium, chloride, sodium, these ions or these electrolytes are positively or negatively charged, and it's the exchange of these that creates that electrical current. So that's why electrolytes can be very important when looking at normal function or conduction function of the heart. So let's take a look at this screen here and let's break it down. Our first positive deflection from the isoelectric line, this small little bump, we refer to this as the P wave. The P wave represents atrial depolarization. It's positive, it's upright, and it's round. This is where the impulse is carrying from the SA node and carries to both the right and left atrium. As the impulse then continues to travel after the P wave, this period of time between the beginning of the P to the beginning of this Q wave is called the PR interval. That is an important factor to remember because the PR interval represents the time it takes for the impulse to reach the AV node. Normal PR interval down here is 0.12 to 0.20 seconds. That's how long it takes. Now, continue moving forward, we get to the first negative deflection represented by the Q, followed by a positive, the R, and then another negative, the S. Altogether, the QRS all represents ventricular depolarization or contraction. The normal time it takes for the impulse to travel to the ventricles, that's your bundles and Purkinje fibers, is duration is 0.08 to 0.10 seconds. Once again, as the impulse continues to travel down the bundles down to the Purkinje fibers, then we see this segment, the QT interval. starts from the beginning of the Q to the end of the T, which is here represented by this other positive deflection. That QT interval represents the time it takes to innervate the entire ventricle. The T wave here is interesting. It's a little, looks like the P wave, but except it's taller and longer. The T wave here represents repolarization of the ventricles. So that means it's repolarizing. Now, notice there is no repolarization of the atrials represented on the EKG. We know it occurs, it's just that it's hidden behind the QRS, and therefore we don't actually see it on the tracing. However, we know that there is repolarization. Basically, repolarization means that everything resets back to the very beginning. So then the whole cycle starts all over again, okay? So T waves is very interesting, and it shows up. Now, the next thing you see here is a little U wave. Now, U waves are not necessarily visible all the time. It does show repolarization of the Purkinjes. And like I said, it's not typically something you would see readily on every EKG strip. If you do see it, it can indicate if it's tall hypokalemia. Whereas you get, this is low potassium. If you have a really tall T wave, what we refer to as a tented T wave, that could indicate hyperkalemia, elevated potassium. So altogether, from the beginning of the P to the end of the T wave, or the U, should I say, this represents one heartbeat. The electrical activities of the atrial ventricular contraction and blood flowing to the heart. Now, we did not mention the R to R interval, which is when we look from one R to another R. We're going to talk about that in a moment when we talk about time. Now, how do we determine how long things are taking? We have to also talk a little bit about the EKG paper or strip. As we can see here, what it looks like is you have 5 small little boxes and then a bold line and then 5. And this is how an EKG strip will look like. It's divided this way. And this represents time. As it moves along, it is telling us how long things move. So to measure and determine the PR interval, for example, we will look at the beginning of the P to the beginning of the Q and count how many boxes are in between. Now, each tiny little box is 0.0 seconds. Once again, tiny boxes are 0.0 seconds. A large, when we look at the 5 boxes between the 2 bold lines, that is 0.2 seconds long. So to figure out the PR interval, if we count how many boxes in between, for example, we have 1, 2, 3, 3.5, maybe 4 boxes. So that's what, 0.16 seconds? Now that's within our normal range, isn't it? So we know that that's a normal PR interval. And we would do the same to measure the QT or the QRS and so forth and so on. I also put a picture here of what a telemetry leads might look like. Now there's an important factor to keep in mind as the impulse travels down the heart. Remember, the heart has the elliptical shape, how it sits in the middle of the chest cavity. The impulse will travel usually from the right arm, travels down this way, as you can imagine what the heart looks like. So you have a positive lead down here and a negative lead up here. There's an important factor to remember that your lead telemetry lead placement is important as, again, the way they're looking at the heart. The standard lead to view is basically saying this is where the camera is. If I had a camera and I'm taking a picture of you and I would look at you from the front, then that's what I would be looking at, the front of the heart based in the lead to position. If I were to move the positive lead and I moved it over to this side, then I would put my camera here and I would be looking at the heart this way. So instead of the impulses coming towards the camera, it's going perpendicular to the camera. If I put the camera up here on this left arm, I'm looking at the impulse perpendicular. And so it gives me different views of the heart. And so therefore the EKG tracing may look slightly different as you would see on a 12-lead EKG, which looks at the heart from all points of view. But we want to look at it from a standard view, or a lead 2 position is what we usually would see in a telemetry and see this configuration. All right. So once again, P represents atrial depolarization, QRS is depolarization of the ventricles, and T represents the repolarization of the ventricles. And like I said, when we looked at that paper, once again, this is a more close-up look at what this looks like. The small box, how much was that again? Yes, 0.04, and 5 boxes between the two bold lines, 0.2 seconds. So let's take a look in practice. How many boxes are in the P to the Q, or the PR interval? What number do you get? All right, if you got 0.16 seconds, you are correct. And that's how we do measurements. Easy? Okay, I hope this is easy enough for you. So let's go ahead and talk about how we're going to interpret the strips. Now that we have a better understanding the way the conduction works, let's take a look at the EKG strips. There is a 5-step process that we're going to use today to look at how to interpret rhythm strips. We're going to start out by determining the heart rate, the heart rhythm, P wave, PR intervals, and QRS complex. As we look at each component and what they represent, it's going to give us a better interpretation. This next slide tells us about hearts that's innervated by pacer cells that are capable of initiating electrical impulses. The cells in the heart have inherent rates. In other words, this is where they feel comfortable, where they function. When the SA node is the one creating the electrical impulse in the heart, basically the boss that's giving the commands, the SA node's inherent rate in an adult is 60 to 100 beats per minute, where the AV node's inherent rate is 40 to 60, and the Purkinje's are 20 to 40. In other words, if the electrical impulse is initiated by the SA node, we expect it to fall between 60 to 100. But if for whatever reason the impulse is coming from the junctional, it's going to be 40 to 60. And then, of course, if it comes from the ventricles, 20 to 40. So let's take the first step. The first step is the heart rate. Now we have to look at both the atrial and ventricular separately when we're looking at rates. So for today's purposes, we're going to be using the 6-second method. Now there are different ways you can determine the heart rate, and we can leave it up to you to research that. But the easiest one for our purposes is just to look at a 6-second strip. And we're going to assume that all of our strips today are 6-second long. So when we look at counting the atrial rate, we said that the P represents the atrial. We're going to count how many P's we can find in this 6-second strip. So we have 1, 2, 3, 4, 5, 6, 7, 8. So multiply that by 10 gives us 80 beats per minute for the atrial rate. For the ventricles, we're going to be using our R waves to represent the ventricles. So we're going to count those 1, 2, 3, 4, 5, 6, 7, 8. Multiplied by 10 is 80. So both our atrial and ventricular rates are 80 beats per minute. The next thing we're looking at is regular rhythm, the rhythm, whether it's regular or irregular. Now, eyeballing this rhythm strips, they do look regular, but to be sure, we can count P to P. So in other words, is the length between this P and this P the same length as this one or this one? You could use calipers to help you determine that, or a piece of paper where you can mark one side and slide the paper over and just kind of see, do they look like they line up? And in this case, it looks like it does. So does the ventricles. So we know that the atrioventricular rhythm is regular. Now, the P wave is an important thing to look at because remember we said that the SA node is represented on the P wave. If there's a problem with the P wave, it could indicate that the electrical impulse is being initiated somewhere else. We'll talk about that a little bit later. So the P wave is produced when the left atrial, right atrial depolarizes, the first deviation off the isoelectric line, and it should be rounded upright. So the P wave is the SA node pacing and firing on regular intervals. And this pattern is referred to as sinus rhythm because it's obviously being created by the SA node, the sinoatrial node. The other thing to keep in mind is, do all the P waves look alike? They seem to look alike, okay? So therefore, that's what we're going to look at. Number 4, we're going to look at our PR interval. Do you remember what the PR interval represents? Absolutely, measures the time interval, the onset of the atrial contraction, and the onset of ventricular contraction. So remember that our normal is 0.12 to 0.20 seconds. So let's just take a look at this one right here because it's a little bit easier to see. So if I count from the beginning of the P to beginning of the Q, which is hard to see here, but we're going to look at 1, 2, 3. Let's say it's 4 boxes. Remember, each box is what? 0.04. Okay, so that gives us a PR interval about 0.16 or somewhere in that ballpark. So that seems to be normal, but we're not done. So we're not only just looking at this PR interval, but we need to be sure that every PR interval matches. So in other words, is this PR interval the same as this one? And so for all throughout our strips. And if we measure each and every one of them, they all come out to 0.16. So again, that's an important factor to remember. It's not only the PR interval, but you're going to learn some keywords like, is it constant? That's our first word that we're going to learn when it comes to PR interval. So the next is the QRS complex. I don't have a strip here to show you, but if we were to look at the previous strip, we would again measure in the beginning of the Q to the end of the S, and that will give us our QRS. Let me go back one strip. And if we were to look at this particular one, it looks like there's one, maybe 1.5 boxes, something like that, 0.66 boxes, 0.06. So that falls within our normal range for the QRS, okay? So that's what we're looking for. Now, let's not forget T and U waves. I mean, they're not going to be used for the interpretation, but just as a side note, remember that what the T wave represents, and I already mentioned about possibility looking at hyperkalemia or hypokalemia, but those are things that we look at. Okay, so are we ready to start and add all this information to our very first strip? Let's take a look. This first strip, what do you see? Let's go ahead and you start with the heart rate, both atrial and ventricle, the rhythm, P wave, PR interval, and QRS complex. Remember, you can pause the video to give yourself time to do that. All right, let's take a look at what we got. So we have an atrial and ventricular rate of 40 beats per minute. We counted the P's, we counted the R's. The atrial rhythm and ventricular rhythm appear regular. The P waves are upright and round. The PR interval are constant and they measure about 0.16 seconds, and our QRS measures 0.10 seconds or so. So everything looks pretty normal with the exception of the rate. Remember we said the inherent rate of the SA node is 60 to 100? So this is what we're going to refer to as sinus bradycardia, because all characteristics of sinus rhythm, but it's slower than normal. Again, we know that the sinus node is what's creating this impulse or this rhythm because we have P waves. Some of the causes for sinus bradycardia could be medications, and primarily that's going to be your main reason why someone would be bradycardia, because look at medications like beta blockers, calcium channel blockers, or antiarrhythmics that can slow down the heart rate. Cases of overdose, especially with barbiturates, can also cause a bradycardia, and other disease process like MIs and increased cranial pressure. Think about symptomology and what you're going to do about this rhythm. Typically, it can be normal in athletes. We don't deal with a lot of athletes in the hospital, but if you did, a sinus bradycardia may be normal. However, typically when you have bradycardia, we're going to treat the underlying cause. So if it's a medication, obviously we're going to stop that medication or deal with the symptoms of an MI or other cardiac issue. Now, there are times when a patient may be extremely severely symptomatic, and that patient may need a pacemaker, for example, or something like atropine. However, you only want to treat bradycardia with severe symptoms. And what are severe symptoms of bradycardia? Well, those are the same symptoms of decreased cardiac output: shortness of breath, dizziness, diaphoretic, low blood pressure. Otherwise, you just kind of monitor and watch. Now it's another rhythm. What do you see? Go ahead and pause the video, do your measurements, and we'll be right back. Okay. So you should have gotten somewhere like 120 beats per minute, both for the atrium and ventricles. They're regular. There's P waves, PR intervals normal, QRS is normal. We call this sinus tachycardia. I'm sure you got that one pretty good. Why? Because the rate is greater than 100, but less than 150. So these are the same characteristics. Now, sinus tachycardia could be more functional. I mean, this is just a normal way of the heart compensating for things like, you're scared or running or anxiety, fear, too much caffeine. This could be a response to fever, stress, pain, maybe dehydration, MI, or it can go into severe heart failure or shock. So typically, sinus tachycardia is not something we're necessarily going to treat. We just want to remove the contributing factors. Maybe treat underlying cause, but most of the time it's just allowing the person to rest. Now, here's another one. Going to get a little bit more challenging. So go ahead and pause the video and we'll be right back. All right, so we got a lot of red here because we have some things that are a little different. First of all, it's really hard to determine what the atrial rhythm is because we can't really determine what the P wave is. We don't have one, so we're going to say NA. However, we can count the ventricular rate, and it's about 160 beats per minute. We're counting the R waves. Again, the rhythm is, we can't tell. Now, the ventricular rhythm looks regular. There is no P wave or PR interval, and the QRS seems normal. Remember, another thing to mention here is when your QRS is normal or narrow, that indicates that the impulse is coming from above the ventricles. Remember when I mentioned the camera? If the impulse is traveling away from the camera, then you're going to get a wide QRS. But when the impulse is traveling towards the camera, you get a narrow QRS. So depending on where it's initiated. So what is this rhythm? If you said supraventricular tachycardia or SVT, you are correct. SVT is an abnormally or fast erratic heartbeat that affects the heart's upper chambers. An abnormal heartbeat called arrhythmia, in this case SVT or PSVT, paroxysmal supraventricular tachycardia, also called. During the episode of SVT, your heart beats very fast. In this case, over 150 beats per minute, up to maybe 220. And what happens here is there's not enough filling time. The SVT occurs when there's faulty electrical connections in the heart, set off by a series of early beats in the atria. When this happens, the heart rate becomes so fast, so quickly, the heart doesn't have enough time to fill with blood before the chambers contract. As a result, you may feel lightheaded or dizzy. You're not getting enough oxygen. In other words, you got less cardiac output because of the less volume. So what do we do in a situation like this? Well, some causes could be pregnancy. In some cases, some women will see SVT, smoking, CHF, lung disease, thyroid disease. SVT can be, like I said, paroxysmal and terminate itself with a vagal maneuver, or for prolonged may need some intervention. And what I mean by vagal maneuver, it could be something like having the patient butt bear down, or cough, or hold their breath and blow hard like they're blowing up a balloon. Those are things that can cause a Valsalva maneuver. So if it doesn't terminate by itself, and this continues, the patient may need to be treated. Some treatment will call for cardiac massage. That's where the physician only can do cardiac massage, where they massage both carotids to create and slow down and create the vagal response. This is not a nurse intervention. Medications can help in this situation, often using calcium channel blockers like cardizem, or give digoxin, are things that can help because it slows conduction and decreases the smooth muscles in the heart. In some cases, if they don't respond to the medications, they may do what we call synchronized cardioversion. And in extreme cases, when the SVT is because of what we call a re-entry tachycardia, means that there's an extra pathway where the electrical impulse just circles around. This is where a doctor may go in and do cardiac ablation. And that's where they insert a thin, flexible tube, catheters through the vein or arteries, and with sensors on the tip of the heart of the catheter. Sometimes they can use either heat or cold to create little tiny scars. That's what an ablation is, to create or block that extra pathway. So these are some of the things that can happen with someone with SVT. You just got to monitor them closely for signs and symptoms of decreased cardiac output. Okay, so that's SVT. Now what do you see? Go ahead and pause the video and do your measurements. All right, we're back. Now this one's an interesting rhythm, isn't it? There's a lot of stuff going on or not going on here. First of all, there is no atrial beat or P wave that we can discern, so we can't do any of our P measurements. The ventricular rate is about 90 beats per minute, but it's also irregular, okay? The QRS is normal, however. So what is this rhythm? All right, you ready? So when we look at the impulse, this rhythm, what's happening here is the SA node is not working. The SA node decided to take a coffee break or went away for the weekend, depending on how long they've been in this rhythm. So what's happening here is you have backup systems in your heart. Thank God, right? So in this case, we have some atrial pacer cells within the atrium that takes over initiating the electrical impulse and the conduction. So let's just say, for the sake of discussion, we have Joe. Joe is a pacer cell in the atrium, and Joe says, listen, I can go ahead and conduct the rhythm. You all follow my lead. Problem is that Joe also has some competition, and Jill says, well, I can do a job just as well as you can. Well, then now Joe and Jill are both trying to compete with each other to get the rest of the group to follow each of them. And then Joan shows up, and Joan says, wait a minute, you guys, I can do a job as well. So now you have competing pacer cells that are all trying to be the leader. And so instead of having a nice coordinated contraction of all the cells receiving the message at once, now you've got all these cells all over the place that are all firing at different times. And so instead of getting a nice coordinated contraction, we get atrial fibrillation, fibrillation or quivering in the atrium. So instead of contracting, it's just moving around in a quiver. So what happens with these electrical impulses that reach the AV node? Now, thank God for our gatekeeper, the AV node. The AV node is there to protect the heart, to send down the signals to the ventricles. But how does the AV node decide which signals to pass down? Well, he may choose to send some of Joe's signals and then said, okay, let Jill get some of her signals through because he's an equal opportunity gatekeeper, and then some of Joan's. And that's why you see this irregular ventricular beat, because it's not being done in a synchronized fashion. Now, what's the problem with being in atrial fibrillation? Well, one of the key things to remember in AFib is that the blood in the atrium is not completely being drained through the ventricles, because some of that is being passed through by passive motion. When the valves open up, that blood flows, but a lot of the blood that's sitting in the atrium are not being pushed down because there's no contraction going on. And we lose about 20% of the cardiac output, or we refer to often as the atrial kick. So patients that go into sudden atrial fibrillation may be symptomatic because they lost about 20% of their cardiac output. However, if it's an elderly sedentary person that's not very active, they may or may not be as symptomatic as someone who would be younger. So what happens is we need to get that back. Some causes could be the valve disease, sinoatrial disease, MIs, COPD, heart failure, cardiomyopathies, to name a few. So this is what's going on here. So we can try to get some of that back. Treatments, we need to first of all determine how we're going to treat it based on whether or not the atrial fib is controlled or not controlled. If it's controlled, we consider that the heart rate or the ventricular rate is less than 100. If it's uncontrolled, that means the heart rate or the ventricular rate is greater than 100, because now on top of not having the atrial kick, we don't have enough filling time, so that 20% could be easily turned into 30 or 40%. So now we have to treat the patient because they're going to be very symptomatic. So what do we do? Again, we want to start out with some medications. The medication, again, we can use is calcium channel blockers like cardizem and digoxin. We can use antiarrhythmics, some beta blockers, and an antiarrhythmic called amiodarone as well. Those are some of the medications that can be used to help convert the rhythm, to slow the heart rate down and convert it. So without the squeezing of the muscle, the blood empties into the ventricles and the valves open. And like I said, we have less blood flow. And some of that blood that's left in the atrium, what happens to it if it's sitting around for too long? You guessed it, it can create a clot. And so now you get clots forming on the lining of the walls of the atrium that can be a real problem if they get loosened up. So sometimes one of the treatment could be synchronized cardioversion to shock the heart back into rhythm, but you never want to do that until you're positive that there aren't any clots that are going to be set free with the shock. So one of the things a doctor may choose to do before doing a cardioversion is a TEE, transesophageal echocardiogram. This is, they'll go into procedure. They can take a look inside to see look at the valves as well as what's going on with the clots. Some patients who are not going to convert, who may become chronic atrial fib, they live with it, may need to go on blood thinners, antiplatelet therapies. So these are some of the things to consider with atrial fibrillation. Again, very common after heart surgery, like a cardiac bypass. Some patients may temporarily go into AFib because of the swelling, and that usually will resolve itself. All right. Okay, learned a lot about AFib. Here's another one. Let's take a look at this rhythm. Once again, pause the video. Okay, we're back. All right. Now in this strip, we have a lot of P waves. In fact, we got too many P waves. If we were to count P to P, we're looking at 300 beats per minute. With atrials, they look pretty regular if you count them out. Ventricular rate, I forgot to put the ventricular rate here, but it looks like it's normal and it's regular. It's really hard to determine which is the P, so it's hard to measure the PR interval. The QRS measures 0.12, so that's normal. So again, what's happening here is we know that this impulse is coming from above the ventricles because our QRS is normal. So what's going on here is that we're going to look at and call this rhythm, you guessed it, atrial flutter. Look at the flutter waves. So these flutter waves are impulses created in the atrium, just like the AFib, where we said that Joe was the first to be in charge. But this time, Joe doesn't have any competitions. Jill and Joan decided to sit back and let Joe take over. So Joe is the one that's created this impulse. And because there's only one area that the gatekeeper needs to worry about, then it's allowing the impulses to go on a regular way or in a standard fashion. So that's why we have your ventricles are normal. So the atrial fib, like I said, similar to AFib, these cardiac rhythm is originating from one foci, F-O-C-I, we call it, one focus or one cell. The gatekeeper will prevent the other signals from getting through. Notice he was not going to let every impulse go through, otherwise your ventricles will be beating at 300 beats per minute. So it allows every 4 beats to go through. That's what we call a 4-to-1 ratio. Sometimes we refer to these, but you can see that that goes through. Again, some causes, again, like very similar to AFib. Digitoxicity could also cause a flutter, alcoholism or pericarditis, valve disease, and a flutter. Typically, patients will not be symptomatic here, so this is not as life-threatening as the other one. Now, let's apply what we've learned. Here's a question for you. A patient presents with atrial flutter with an atrial rate of 280 beats per minute and a ventricular rate of 70 beats per minute. Which of the following best explains this discrepancy in rates? Go ahead and pause your videos while you think that one through and then select your answer. All right. If you selected B, you are absolutely correct. The AV node does not conduct all the atrial signals in the ventricles. Again, this is our gatekeeper that's keeping track and protecting the heart and the ventricles. All right. Let's move on. Here's another rhythm. A little bit more work for you. Okay. So what do we see here? Everything's pretty interesting. Looks like a sinus rhythm. Everything looks like it works out with the heart rate, ventricular rate. It's regular. P's are there. But we see something here that's the PR interval that measures 0.36 seconds, but it's constant. Well, that seems pretty far, doesn't it? As we know that our normal is 0.12 to 0.20. So with that in mind, what is this called? Well, this is the first of our heart blocks, first degree AV block. First degree AV block is a signal that comes from the SA node to the AV node, but it's just taking longer for that impulse to reach the AV node. Therefore, the PR interval is prolonged, but it's constant. I like to think of my blocks as relationships. When I think of analogies, one of the analogies I like to use for first degree is I think of the older couple that's been married a really long time. They seem pretty comfortable with each other. They know each other pretty well, but they don't necessarily need to be cozy and holding hands all the time. This may be the couple that sleeps in separate bedrooms, not because they don't like each other, but they don't want to hear each other snore. They're fine with their relationship, but they may be further apart, but they're together. So I think of the first degree AV block as the older couple. Okay. So again, keep in mind some of the terms that we're going to be talking today. And the key for first degree AV block is you have a prolonged but constant PR interval. Again, some drugs that can cause this, imbalances, hypothyroidism. Most of the time, clinically, it's insignificant. It could be a precursor to other blocks, and treating the underlying cause. Most patients will not have any symptoms. They won't even know they have it unless they're on a heart rhythm monitor, but typically they won't even know. Here's another one. Go ahead and pause your video and do your measurements. All right. Gets a little more complicated as we go, don't we? Now what we see here. Now let's take a look at this one a little more closely. So I don't know if you can see my cursor, but you can see that this is a P wave. If I count these P waves, 1, 2, 3, let me make my thing, 4, 5, 6, 7. So I have 7 P waves, so I have 70 beats per minute for my atrial rate. However, my ventricular rate is only 1, 2, 3, 4, 5, 50 beats. So now we have a discrepancy between your atrial and ventricular rates. The atrial rates are irregular. If you look at the spacing between P's, this space is much longer than this one. So we have an irregular as well as irregular ventricle. Now the P waves are upright and round, but the PR interval is very interesting. So let's start with this grouping here because it's just clearer to see. So let's start with this grouping. If I look at the PR interval here, we have a prolonged, we got 1, 2, 3, 4, 5 boxes. PR interval is right at the upper limit of 0.2 seconds long. Now remember, we have to measure that every PR interval is the same. Now, if I measure this one, we got 1, 2, 3, 4, 5, 6. Now, this one is 1 box longer than the first one. So now we have a lengthening PR interval. And this one looks even longer yet. 1, 2, 3, 4, 5, 6, 7. So this one we had 5, 6, 7. And now we have a P wave. Oops, we have a drop beat. And then it starts all over again. Okay, if this strip continued, we would see that 5, 6, 7. So what are we seeing? A PR interval with a lengthening PR interval with an eventual drop beat. Okay, once again, the PR interval is lengthening and eventually has a drop beat. In this case, we have a 3-to-1 drop beat. Ventricles are normal. So what are we going to call this rhythm? This is a second degree block type 1, a type 1 second degree heart block. Another old name you might remember is Mobitz 1 or Winky Bach. You might, those of you who've been around a while, probably remember Winky Bach as determining the second degree type 1. This is a progressively lengthening PR interval. And the example here, we have like a 3-to-1 block, eventually dropping. I like to think of this one to help me with my little analogy of couples is think about the fighting couple. The P is the wife that gets very angry at the QRS, who's the husband. And not being sexist here, we can turn it around if you'd like. But in this case, the wife says to the husband, you can move over to the other side of the bed because she doesn't really want to talk with him right now. And then says, you got to move over. Really don't want you near me at all. Then sends him to the couch and says, you can go sleep in the couch. So the husband gets further and further away from the wife until eventually she kicks him out and says, go home to your mama's house or to a hotel. The idea is that they're angry, they get further apart until he leaves. But just like any fighting couple, he comes back and says, baby, I'm so sorry. Here's some flowers, some candy. They make up. Unfortunately, the whole fighting starts all over again. So if you want to remember it this way, think of the fighting couple. Remember, our first degree is the old married couple that are very happy, but having distance between them. But this is the fighting couple. Does that make kind of sense? So what's happening here? Again, causes can be similar to what we've already talked about. We talked about electrolyte imbalances as well can causes. Prognosis is good. It's usually asymptomatic, especially if the ventricular rate is good. If you maintain, above 50 or 60 ventricular rate, you typically won't have any symptoms. So you're going to just treat the underlying cause. Now, this could be a real precursor to further blocks that could be more serious. So this is something that you want to monitor closely and monitor and treat the cause. All right. What about this one? Pause the video, do your measurements, and we'll be right back. All right. Interesting looking strip, isn't it? Now here we have an atrial rate of 100 beats per minute. Why do I say that? Because if I'm counting here from this P wave, we have 1, 2, 3, 4, 5, 6, 7, 8, 9, and 10. Okay, that gives us 100. But if you look at the ventricular rate, it's 40. All right. They're regular. If you bounce this out and measure between P intervals, just P's, they are normal. If you use your caliper or paper, you'll see that the distance between two P's are regular. So is the ventricular regular. P waves are upright. But let's take a look at the PR interval because that's what makes it a little bit interesting. Let's take a look at this PR interval. It's 1, 2, 3, 4.5, maybe boxes. Let's look at this one. 1, 2, 3, 4.5 boxes. 1, 2, 3, 4.5 boxes. So wherever there's a complete complex of PQRST, the PR interval is normal. The problem with this rhythm strip is there are some P's that don't have a QRS with it. So some P's are alone. This is what I call my cheating husband. The cheating husband. There's more times when he is out than when he is home. We call this rhythm second degree heart block type 2 or Mobitz 2. Once again, we have when the husband is at home, everything is good and normal. He's a good boy. He's behaving. But there's a lot of time when he's away. He could be a traveling salesman or he could be out somewhere doing what he's not supposed to be. But he's not home. So this is another way of remembering this through using the relationship analogy of the cheating husband. Okay? So again, the P waves and QRS there's more P's alone than there are QRS's. And typically you're going to find that the ventricular rates are going to be half of what the atrial rates are typically. There's always going to be drop beats without warning. So what's going on here never happens in a healthy heart. So this is something that you really need to pay attention to. Unlike the other heart blocks that could be mild or asymptomatic, this is something that can really seriously cause problems. Usually from an MI or severe coronary artery disease, cardiomyopathy can cause heart blocks. So this is something that needs to be treated. So we treat, most of the time it's going to be done with an immediate pacemaker. All right. Notice that it's a slow ventricular rate. This is not where you would use atropine. Atropine will be contraindicated in using in heart blocks, but you can use a pacemaker or eliminate maybe other underlying causes, treat the underlying cause, or it could be some medications as well. So we always want to look at our medication list, make sure those are not contributing to this. Okay, so second degree heart block type 2 is your cheating husband. Now what do we see? Go ahead, pause the video, measurements, and when you're ready, start it again. Okay, we're back. So let's take a look at this. Now we have an atrial rate. Believe it or not, we can count the atrial rate and they are regular. The thing to look at this is sometimes the P wave can be hidden in the QRS. So for example, this is a P, and if we march it out, this is a P here. It just landed near the T wave. This is a P, a P, a P. Here we go. Follow the bouncing cursor, and you can see and count your P waves, and you can see that they're regular. In case you missed it, here's a P, there's a P right here. And if you use your calipers, you can see how they easily measure all the way through. The ventricles are regular as well, okay? So we have P waves, PR interval, let's take a look. Wow, that's a really long PR interval, isn't it? Now notice that this one is not as long as that first one. And this one is a very short P, and then if we had a longer strip, you would see this was longer. So what we call this is a varying PR interval. In other words, there's no rhyme or reason. The PR interval, there's no constant, there's no it's not lengthening, it's varying, it's all over the place. The QRS is awfully wide as well. So what's happening in this heart? Okay, there doesn't seem to be any communication between what's happening in the atrium and what's happening in the ventricles. They're not speaking to each other. What is this? A third degree heart block or complete heart block. This is a complete heart block that's going on. Complete heart block means there's a disassociation between the atrium and ventricles. So the atrium is pacing independent of the QRS. In other words, the sinus node is doing its job, initiating this electrical impulses, but somehow the conduction never makes it to the ventricles. So the ventricles decide, look, if we're not going to get help from the atrials, then we're going to do our own thing. So this is what I refer to as our divorced couple. They're no longer together. This requires immediate intervention. With a slow ventricular response, such as this first example, the cardiac output is severely compromised and patients likely very symptomatic. All right. So what are we going to do? Now, you notice I have two different strips. They're both heart blocks. I mean, they're both complete heart blocks. The difference is this is narrow and this is wide. Remember way back in the beginning, I talked about that camera again? If the impulse is coming from the ventricles, is initiated like it is here, then the impulse is going to go away from the camera and you get the wide QRS. This is what we call third degree heart block bundle branch level. Now we're getting to advanced EKG. Don't worry if you don't remember this. This is not something that's going to be on your NCLEX. But just for your own understanding, there is what we call a complete heart block at the bundle branch level, meaning the bundle branches are creating the ventricular beat. Where the second example here, again, it's still complete heart block because the PR intervals are all over the place. They're separated from the ventricle, but this is a complete heart block AV nodal level or AV level block. I know, you're thinking, crazy, isn't it? The idea is that you have to look at the PR interval and you have a varying PR interval in both these examples, so they are both complete heart blocks. And like I said, this is the way we describe it: serious compromised cardiac output, and he needs or she needs an immediate pacemaker, because the second one, they may be able to tolerate it for some time, but they've lost some of their atrial kick here. And this one is very slow cardiac output, so they need a pacemaker to fix that until they can treat the underlying cause. Okay? How about this one? Okay. So what this is just a normal sinus rhythm. The only thing different is this thing that just landed right in the middle of this rhythm strip. So the underlying rhythm, we refer to as the underlying rhythm, is normal sinus rhythm because it meets all of the criteria of normal sinus rhythm. But we have to kind of look at the elephant in the room, as they say. What is happening here? This is an ectopic beat or an escape beat. It is wide and bizarre looking. Where is this impulse coming from? You guessed it, it's coming from the ventricle. Remember, if it's wide, it's coming from below the ventricle. So what's happening here, this is an escape beat that escaped from the ventricle. We call this a premature ventricular contraction, or PVC. Premature because you notice it does come in early and then the heart resets itself back into the normal rhythm. And so we have PVCs. So we can have what we call uniform or unifocal PVCs, where the PVCs look alike. They're all coming from one foci. Remember, we said that one impulse in the ventricle that's creating this beat. Or we could have multifocal PVCs, like in this example. Multifocal means that these impulses are being created by different cells in the ventricle, which is a little bit more ominous because it's telling us that something is irritating the ventricles. They're not liking what's going on there. So they get irritated and you have these escape beats or premature ventricular contractions. Can be caused by things like caffeine or certain medications that increase the metabolism. We have diet medicines. There's a lot of medications that FDA had to pull off the market because they created a lot of cardiac issues, including extra PVCs. Electrolyte imbalances can cause that, like hyperkalemia, hypoxemia. Heart doesn't like not having oxygen. MIs, again. So you're going to treat the underlying cause. Most of the time, it's not significant if it's here and there, but if it's receiving a lot of them, a lot of PVCs, that's something that you need to pay attention to because it can lead to something a little bit more serious, such as this next rhythm. What do you see? Okay, so what we're seeing is a lot of, we have no atrial going on at all. All these are is a whole bunch of PVCs all in a row. These are all ventricular beats, all coming from the ventricles. They're wide and bizarre. We can count them out. We have a ventricular rate. It's supposed to be, 160, not 1600. That's a typo there. So it's pretty fast. Ventricular rate. It's all ventricular. What do we call this? You guessed it. It's ventricular tachycardia. VTach. Now, something to be important. First of all, there's no relationship between the atrium and ventricles. The atriums are just not even in the picture at all. Ventricular tachycardia is life-threatening and needs immediate intervention. The approach is dependent if there's a pulse versus no pulse. This is important. This could be an NCLEX question if you get this rhythm. So life-threatening, you got to first determine if this pulse has got VTach with a pulse or is it pulseless VTach. Now, further assessment includes after determining whether there's a pulse or no pulse, then we're going to determine whether it's stable versus unstable. Okay, so if ventricular tachycardia with a pulse, but not symptomatic, we have time to treat it with medications. In other words, if their symptoms are mild, meaning their blood pressure is stable, typically that's a good sign that they're stable, even though they may feel like mildly dizzy, some shortness of breath, but their skin is warm and dry, the blood pressure is okay, that means you have time to give medications like antiarrhythmics such as amiodarone, for example, that can be given. Back in my day, we used to give lidocaine. It's still around, but amiodarone is the drug of choice, antiarrhythmic that can be given in a bolus type, not a bolus, in an IV form, IV piggyback. You don't bolus someone with amiodarone that has a pulse. So you give 300 milligrams in a IV piggyback over 15 minutes to be able to start, and then you start an amiodarone drip. Now, what's going to happen is that can hopefully convert this rhythm back into normal rhythm. However, what happens if they're symptomatic? Their blood pressure drops, they're diaphoretic, there's shortness of breath, they may be having some chest pain, all these things that you don't have time for the medication to work. This is where you're going to go into symptomatic, you're going to do synchronized cardioversion. Now, you've heard me mention synchronized cardioversion. What basically that means? It means that you're going to synchronize your electrical activity, that you're going to create that shock with the heart itself, because you don't want to shock the heart and for that shock to land on a vulnerable area of the heart, mainly around the T wave. If you land on the T wave, that can cause more damage and more serious problems. You want to avoid landing on that vulnerable area. So you want to synchronize your shock with the heart rhythm, and that's done through the defibrillator device. You push the synchronize button, okay? So what causes this? As you can imagine, some of the same things we've already talked about, PE, hypokalemia, drug toxicity, overdose, and just to name a few. So that's what you would do for someone with VTAC with a pulse. Now, what happens if you see this rhythm and the question says there is no pulse? If there is no pulse, then you would initiate your ACLS protocol. You start CPR and you want to defibrillate as soon as possible. Defibrillate is different than cardioversion, that you do not have to synchronize with the heart. You just shock the heart and follow the ACLS protocols. Okay, so that's ventricular tach. Let's try another question. It says, on a telemetry monitor, the nurse observes that a patient's heart rhythm is sustained ventricular tachycardia. Upon assessment, the patient is alert and oriented with no reports of chest pain, but expresses feeling of slightly short of breath. His blood pressure is 108/70. What is the nurse's initial action? You can pause the video, think about it, select your answer. Okay. If you selected D, you are correct. All right. Now, let's look at A, synchronized cardioversion. Remember I said that would be used only if the patient was unstable. This patient doesn't seem unstable. Blood pressure is stable. They don't seem to be having any chest pain. So we would probably want to deal with them with medication. We're not going to do CPR because they have a pulse. Now, between C and D, why did I pick D? So even though giving IV amiodarone and dextrose would be appropriate for this patient, the initial thing you want to do is apply the oxygen, observe the heart rhythm. Now, remember, it's initial or first action. Doesn't mean that we're not going to give the amiodarone, but remember that's how NCLEX style questions work. A lot of times they try to not fool you, but try to get you to think about first step, second step. First step is you want to apply oxygen. Remember, the heart is under a lot of stress when it's in VTAC, and it needs all the oxygen it can get to maintain and support it. Then you can proceed to give things like the IV amiodarone and dextro, which is going to take you a little bit more time to do. So oxygen would be the first answer, right? Now, what do we see? Let's pause this for a moment. And we're back. All right, this is another weird looking rhythm. There's nothing here that we can measure. Nothing is discernible at all. It's just a wiggly line. So what's happening here? Similar to what we talked about in atrial fibrillation. This heart is fibrillating, but it's the ventricles that are fibrillating. Nothing is coming from the atrium. The ventricles are the ones that are trying their best to try to create a impulse, but they're not able to. There is no contraction. There is really nothing that's going on. There is no cardiac output. This is a patient that's in ventricular fibrillation, which basically is the same as someone who's dead. You got no cardiac output, but you have electrical activity attempting to do something. So there's no discernible rate, no organized rhythm, and this is something that you would do with an ACLS protocol. You would be doing CPR and defibrillating as soon as possible. VFib can imitate electrical interference with telemetry equipment. So make sure that when you see a rhythm like that, that you're validating that it's a true VFib, a ventricular fibrillation. Again, things that can happen are most of the time caused by MI, or the VTAC can then progress to VFib. Electrolyte imbalances, drug toxicity, overdose, shock, hypothermia, such as in drowning. And what we're going to do is treat it with drugs and shock, which is the ACLS protocol for that. Okay, so this is ventricular fibrillation. And let's take a look at this one. All right. This is no discernible anything. The top one is someone who is in what we call asystole, right? So asystole is there's no electrical activity at all. Unlike your ventricular fibrillation, there is some electrical something going on there, even though it's not contracting anything. In asystole, there is no electrical activity at all. So there's nothing to shock. There's nothing we can really do with someone in asystole except CPR. You could do some medications like epinephrine, but typically this is a patient that's probably dead already. Now I wanted to show you the second strip, which means that the leads are off. So just make sure that, again, if you see a rhythm strip like that, you're validating that this is not just some equipment failure and the patient is asleep, but that they're true asystole. So again, this is someone who basically is dead. There's nothing going on electrical. Okay. Now, I did want to show you one more PEA, pulseless electrical activity. This is just a EKG of different rhythm strips. Basically, what pulseless electrical activity is any clinical condition characterized by unresponsiveness and lack of a palpable pulse in a presence of an organized cardiac electrical activity. In other words, you can see an electrical activity and identify a rhythm, but the patient has no pulse. They're dead. So again, you're going to treat them with CPR and ACLS. So that's what PEA, or pulseless electrical activity, means. There is an organized cardiac electrical activity, but it's not creating the contraction, and therefore there is no pulse. All right, let's apply our knowledge. A female client with cardiac monitoring has a rhythm that looks like ventricular fibrillation. Which of the following actions should the nurse take first? Pause the video, think about the question, select your answer. All right. So if you said A, you are correct. Palpate for carotid pulse. Remember, the key word here is that the looks like. In the stem of our question, it says the monitoring has a rhythm that looks like ventricular fibrillation. Remember, I said that ventricular fibrillation can be mimicked by electrical interferences. Even somebody brushing their teeth can look like they're in VTAC or VFib. So you want to make sure to assess whether or not this is true. So don't look over those keywords. Your patient has an altered level of consciousness and a pulse with a blood pressure of 90 systolic. The monitor shows the rhythm below. What will the nurse prepare? All right. If you selected C, synchronized cardioversion, you are correct. This is a patient that's showing VTAC, but they are having symptoms. They're symptomatic. They have a low blood pressure, the altered level of consciousness. We don't have time to really medicate. We want to go ahead and immediately synchronize cardioversion. We don't give adenosine to VTAC. Actually, adenosine is a good medication often used for SVT. Didn't mention that earlier, but SVT can be, adenosine can be used with SVT. Digoxin could be used for your AFib, SVTs, and any rhythm that you want to slow the heart rate and conduction. And of course, if they have a pulse, you're not going to defibrillate, right? So there you go. And there you go. It ends our webinar for today. I hope this was helpful to you. I know we covered a lot of information and maybe things that are overwhelming you. Remember that there are other studies and other supplemental studies that you could do. You can go to registerednursern.com and you can look at some of their videos that they have on EKG interpretation and other materials that we have. If you have any questions, don't hesitate to reach out to your instructor. We're here to help. So thank you again for joining. And until next time, enjoy our webinars. Bye, everybody.